So I do have some conflicts. Angel Eye is a camera system for the nursery that's a company spinoff, and AirToco is a device for monitoring patients in labor that's a throwaway. And this study, however, was conducted by our MFM fellow. We have a fellowship program at the university in maternal fetal medicine, and the idea was to compare ultrasound, how accurate are we, teleultrasound, how accurate are we. And so we started Angels in like 2003, and the first site was in Northwest Arkansas at a brand new hospital, and we decided, we were doing video conferencing for education for many years. We decided to do care. We were trying to do MFM care, maternal fetal medicine care. In Arkansas, we're the only teaching hospital as well, and at that time there were only 3 maternal fetal medicine physicians in the entire state, and they were all at the university in Little Rock, and Fayetteville was about 2.5 to 3 hours away from where we were in Little Rock. And so the idea was to provide MFMs all over the state, and the program grew, and as we developed the platform, we added other things to the program over the years. It started with a T1 line that we hooked up to an ultrasound machine, and we would do MFM consults with genetic counselors and ultrasound interpretation at the very beginning, and then we just spread to other sites all over doing the same thing. So in pregnancy, in maternal fetal medicine, the mainstay of what we do is there are 2 patients, and it's a balance between the 2 patients, the mother and the fetus. And you have to sometimes do things that might be harmful to one or the other of them to do something for the one that needs it the most. So in pregnancy, a lot of the things we do is we look for congenital anomalies in the developing fetus, so we kind of screen the population. This requires a high level of expertise. Usually only at tertiary care centers can diagnose many of these congenital anomalies. And so prior to starting the Angels program, every patient had to come to Little Rock to get an ultrasound if there was some question about it. When we started the program, we decided that could we look with telemedicine through the ultrasound machine and then make the diagnosis remotely. And so we started it. And so it's well established that from many trials that using ultrasound to diagnose these abnormalities of the fetus have you to better, it allows the women to have choice about whether to continue the pregnancy. You can decide whether to transfer the patient to deliver at tertiary care centers where the nurseries can take care of these children with anomalies, and it helps you decide where to deliver the patient. And so, like all testing, there are variations in sensitivity, specificity, and accuracy of the diagnoses. And there is some evidence that skilled individuals with more costly ultrasounds can do a better job than less skilled individuals. So, like I said, we had the Angels program, and we started the Teleultrasound program associated with this. But the other thing that we have is we have this Arkansas Reproductive Health Monitoring System, ARHMS, and this is a pediatric-run program that's been established for many, many years. And they basically go in and look at all newborns and make diagnosis of congenital anomalies. They train the local nurseries, and when questionable, they go in and look at the baby and make the diagnosis. And they have a well-established, over many years, database that then could be linked with the ultrasound. And that was kind of the concept of the project. And so this Arkansas Center for Birth Defects Research and Prevention goes in and looks at all these babies and establish this is a nationally acclaimed birth defects surveillance system. And so the aim and the hypothesis of this study was determine the sensitivity and accuracy of teleultrasound. And so we hypothesized that the sensitivity of ultrasound is greater than 40%, and accuracy is greater than 90%. And that national papers say that. You would think that it would be more sensitive than that, but this includes all congenital anomalies, many of which are very difficult to diagnose, like ventricular septal defects of the heart are very, very hard to diagnose. And so the secondary outcome was to determine how many ultrasounds that you did in this project. So with the idea being that if you did, twice as many ultrasounds in teleultrasound, then that might offset some of the cost savings and benefits because you're just doing more ultrasounds. And so it was a retrospective cohort study following the strobe checklist, which I'll explain in just a second. IRB approved, and inclusion criteria was just that they had a teleultrasound. We excluded patients if they had an ultrasound, the only ultrasound was prior to 17 weeks, if there are multiple gestations, and if the ultrasound was performed other than anatomic evaluation. We do ultrasounds for other reasons, like Doppler studies, follow-up growth, and other things. So these were only studies that we're doing anatomic evaluations on patients, and most patients have an anatomic evaluation now somewhere between 18 and 24 weeks. And so the strobe is strengthening the reporting of observational studies in epidemiology. And the strobe statement consists of a checklist of 22 items which relate to the title, abstract, introduction, methods, results, and discussion session of articles. 80 items are common to cohort studies, case control studies, and cross-sectional studies, and 4 specific to each of these 3 study designs. So the questions were developed prior to looking at the ultrasound reports. And so the methods of this cohort creation were ultrasound reports, August the 12th, 17 weeks gestation. And then, of course, there's a lag time from the time the ultrasound is done until the delivery for follow-up of the newborn evaluation. And then the birth outcome data, 2010 to 2012, 41 weeks EGA. And so retrospective cohort study, also called historical cohort study, is a longitudinal cohort study that studies a cohort of individuals that share a common exposure, in this case, ultrasound. So that was how the patients were entered. And development of the disease, in this case, what was the incidence of congenital anomalies in the population, and how many did we miss, and how many false positives did we have? So the methods of data extraction, ultrasound reports were manually reviewed, and we collected on the sheet that we developed demographic data, gestational age, number of ultrasounds required to complete the study, presence and type of anomalies, and soft markers seen, amniotic fluid volume assessment, and placenta, uterine, and maternal anomalies were not collected. And we started with 2,499 studies. We excluded 131 due to multiples, like we said, less than 17 weeks, 3 duplicates, and other indications. And there were 2,368 studies in the project. And so this is the descriptive statistics in this. The sensitivity, 53.96, specificity, 98.14, positive predictive value, 64.66, negative predictive value, 97.12, anomaly prevalence in the population was 5.94, and accuracy was 95.51. So when you look at this, this is, of course, all anomalies. And so if you break it out into different kinds of anomalies, some are easy to diagnose, some are more difficult. Anencephaly, which is a neural tube defect in which the fetal head fails to develop, and it's a huge, gross defect, easily diagnosed by less skilled individuals. You'd think, well, you should be pretty accurate with that. Cardiac septal defects, which are very small defects in a very small structure, you might miss that more frequently. And so, you can see that's kind of the way it turned out with the false negative result, which means that we didn't see it. And then renal false positive, that's often overcalled, and you can see the distribution. And then if you look at the initial ultrasound at any gestational age, first ultrasound, so this is how often you bring the patient back to do another ultrasound. So if you don't see enough structures or you think you're missing things, you bring them back for another scan. And so you can see how this broke out. in the population. If the initial ultrasound was prior to 22 weeks, where we've excluded the ones that were done later, you know, we brought the patients back at about this rate. Overall, complete anatomic review was 88.9%. And so discussion of the false positives. False positives would be a patient that you thought they had an anomaly and they didn't have an anomaly. And so the false negatives in this group represents limitation of prenatal diagnosis. A ventricular septal defect or atrial septal defect is excluded. You know, so, and again, this is the heart in the fetus is very, very tiny. The ventricles are very tiny and the atria are very tiny. And if the patient is obese, even at the university in our anomaly center, we often miss some of these. So if you exclude that group, the accuracy was 98.2%. And so the strength of the study is a unique design. It's the largest of the kind in the literature. The really power of this study is that we had a near gold standard for determined accuracy because of the pediatric diagnostic center at the school with this large database and internal validation of birth outcome data. And so limitations, it was a retrospective nature of the study. It was clinically complete exams reported as incomplete. So a lot of times the doctors interpreting the ultrasounds initially would report them as incomplete, but when we reviewed it, they were actually complete. So non-detection of third trimester anomalies we didn't really do or look at. And there was no true control. We didn't randomize in this study from one that got the ultrasound and the teleultrasound, the other one didn't get teleultrasound, or even moving the ultrasounds we did in the community to the school for that kind of comparison. And discussion, teleultrasound is equivalent to the current literature standards, you know, from this study in terms of sensitivity and specificity. Teleultrasound can potentially result in significant cost savings and benefits to the patients by avoiding tertiary care. Okay, and there's just the people conducting the study, Pat McGann and Sandlin and Wendell. These are all maternal fetal medicine people within the department. So that completes the study presentation. Thanks.